didn't mean to. So, anyway, what did we talk about yesterday? Okay, I know you guys got micro in the brain. Just stay with me for a little bit today, all right? So, hypothalamus, what does it do in a nutshell? Master, yeah, right? It creates, what does it make? Hormones that do what? That essentially tell the pituitary to do something, right? Or to make something, correct? Right? Okay, so 2 large buckets of the hormones that it makes are the releasing hormones, right? And the inhibitory hormones, or the inhibiting hormones, right? So it's going to tell the pituitary, make this thing or stop making this thing, right? Based on positive or negative feedback loops, correct? All right, so travels down to the pituitary. 2 main parts of the pituitary, anterior and posterior, okay? The anterior, what's another name for it? Anybody remember? The adenohypophysis, right? In the back, pars nervosa, the neurohypophysis, right? You guys remember that? Okay? Also, anterior is pars distalis because it's farther away from the hypothalamus. So again, 7 names for different things. I just want to go over all the terms. Everybody still with me? Okay? So, adenohypophysis, what does it do? Anterior pituitary, what does it do? It makes stuff. That's what I'm looking for. Just generic terms, you guys. It makes stuff. All right? And the stuff that it makes, what do those things do? Tell target tissues, tell other glands to do something, right? Very generic. Everybody follow me, right? All right, exactly. How do the hormones from the hypothalamus get to the anterior pituitary gland? Portal system. Hypophyseal portal system, right? Bypass. Is the anterior pituitary directly connected to the hypothalamus by any anatomic portion other than those vessels? No. Exactly, right? Okay, good. What happens in the posterior? Storage. Garage, right? How do the things get down to the posterior pituitary? Neurons, nerve cells, neurosecretory cells where they're then stored until it's time for them to be released to go do something, right? And how do the things in the pituitary get out into their target glands? Veins, hypophyseal veins, through the venous system, right? Okay? Yes, sir.
Is it that the posterior pituitary does not make anything?
That's right. That is correct. And again, I want you to think about the anterior and posterior pituitary, although they are a gland, as 2 separate things. All right? It's just easier to think about it that way. And clinically, that's the way it really does work. Anterior pituitary makes stuff. Posterior pituitary stores stuff. Okay? Again, if you want to think about it, pars nervosa, neurohypophysis. Nerves, connected by nerves to the hypothalamus. All of the nerve stuff on the back side, all of the making stuff on the front side, okay? Easy enough, I guess, for right now? All right, good. And then HGH talked about human growth hormone, right? What is it? It increases gluconeogenesis, glycogenolysis, right? It makes building blocks for us to rebuild muscle, rebuild bone. It is released during the initial part of very deep sleep when we're in a restorative state. Does all that make sense? And all of those things back to modulated, mediated by the somatomedins, which are the IGFs. Okay, that's a quick summary of yesterday. Does anybody have any questions? All right, so let's go to today. Today we are going to finish anterior pituitary. We're going to do posterior pituitary, which is very quick, and then we will start our discussion on thyroid, or we'll go through thyroid and parathyroid, okay? And then we'll leave it there, and I'll let you guys on for the rest of your day. So, adrenocorticotropic hormone. What is it telling? What is it acting on? The adrenal gland, right? The adrenal gland, and specifically the adrenal cortex in general. Yes, right? Okay. So, how does the anterior pituitary know it's supposed to make ACTH? Corticotropin releasing hormone from the hypothalamus, right? And what type of cells make ACTH in the pituitary? You guys remember those? Corticotropes, right? So there is some similarity. There is a tie that binds some of these words together, okay? And again, very brief summary of what it does. Again, we're just at the hypothalamus telling the pituitary to make something. Now the pituitary is making this thing. Tomorrow we will discuss what it does in the adrenal gland. But for now, this is sufficient. Make sense? So if you're thinking there's got to be more, there is, but that's not what we're talking about right now. All right? And again, you remember what we talked about. Androgens, a lot of the steroid hormones, the corticoids, ONs, O-N-E. Remember those? Those lipid-soluble hormones that end in O-N-E. Most of those are made in the adrenal glands. Also some in the kidney, some in the adipose tissue, right? So, shorter list. Amino acid hormones, long list. Lipid-soluble hormones, much smaller list. Again, the simple memory tricks you can give to yourself, they don't just help here, they help in real life. Memorize short lists, not long lists if you can. But did everybody remember what I'm talking about? Okay. Prolactin. Okay, so named because that's what it does. Prolactin releasing hormone from the hypothalamus. That's right. Dopamine, prolactin inhibiting hormone. Dopamine is another one of our friends that is a hormone and a neurotransmitter, so it has multiple different roles. In this milieu, we're talking about it as an inhibitory hormone to stop the prolactin production. So what things stimulate prolactin production? Well, the high estrogen environment of pregnancy, for one, stimulates estrogen production or prolactin production to stimulate milk production. Okay? Then following pregnancy, when the estrogen levels drop, what sustains prolactin in that postpartum environment is suckling, is the baby feeding. All right? Once that is over, once breastfeeding is over, estrogen levels rise, and prolactin is inhibited. Okay? But that's sort of where the chain goes. But for right now, we're going to talk about that again. We get to go to autotrophs, but for right now, the hypothalamus makes those things to tell the pituitary to either make prolactin or not make prolactin. Okay? And if you just want to make it simple, in a non-pathologic environment, does there need to be milk production or not? Okay? Fair enough? Too fast? We're good? Good. I just want to make sure. I know I can speed up when I start getting excited. Prolactin hypersecretion. Remember we talking about a prolactinoma or pituitary adenoma yesterday that would affect your vision? So most of those, I would say, I don't quote me on any percent, but most of those pituitary adenomas are going to be prolactinomas, actually. All right. So, speaking of that, what kind of cells make prolactin? Lactotropes. Okay, remember that? Okay. So, anyway, if you have vision difficulties, if you have a male patient who is experiencing nipple discharge, it can be from a prolactinoma. It can also be from steroids. Okay, I have seen that. So, doc, is it normal for me to be lactating? No. So you see, I am too, as a matter of fact. But I'm sure they Google. I'm sure back in those days it was WebMD, so I'm sure WebMD told them. You know what I mean? But if you see this right here, why this is affected, there's that optic chiasm, again, which is the crossing space where the two different optic nerve tracts cross out of, so they come this way. And you get this huge pituitary adenoma, you get this compression right here of that optic chiasm. And it results in a really weird visual loss, okay, bitemporal. Right? And then eventually.
It's an optic nerve tract.
Optic chiasm. So the optic chiasm in there and the optic nerves come out of the optic chiasm.
But optic nerves aren't optic nerves, they're tracts.
Yes.
Central nervous system, right?
Uh-huh.
You said nerve.
you're better than me? Would you like to come up here? I'd like to see you. No, I'm just kidding. No. He's right. It's optic tracts, whatever. Optic nerves. You're gonna. I mean, so the cranial nerves come out of there and then are contiguous with your retinas, right? But the way that the optic tracts are, two different nerve pathways innervate two different sections of your retina. So your retina isn't innervated uniquely by one side. So depending on where the lesion is, different fields of vision can be lost. When you have an optic chiasm one, usually you use the outside fields of vision called the bitemporal hemianopsia. So if the patient describes, what you can take away from that until you get to ophthalmology is if the patient starts to describe some weird visual loss, think about maybe something impeding on the nerve itself, the tract itself.
Real quick.
Yeah.
With that picture, I'm confused by the view. Is that transverse and then is the bottom posterior?
Yeah.
I just wasn't sure where the optic chiasm is compared to the.
So here we have sinuses, right? So
Oh, so that's anterior.
you're looking here,
Okay.
right? And you're cutting off back here. Essentially, you're looking at sort of a sagittal section. All right. This is the brain.
Oh,
All right. See, you guys are getting froggy today. All right. All right. Follicle stimulating hormone. It stimulates follicles. Okay. What type of cell makes follicle stimulating hormone and luteinizing hormone? Gonadotroph. Okay. Very good. So we will have long discussions about follicle stimulating hormone and luteinizing hormone when we get to the reproductive section. I assure you. For now, follicle stimulating hormone is not ironically named. It initiates follicle production, right? So the stimulation of the follicle to become mature ovum to release the egg, right? Okay. Spermatogenesis in men, sort of the analogous production, sort of the analogous physiology in men, all right? Luteinizing hormone, sister hormone to FSH. And when you talk about FSH, you talk about FSH and LH as a pair, because they have complementary physiologies. Okay. Triggers ovulation and triggers testosterone production. To draw your attention to this, does anybody know what the corpus luteum is? So after ovulation, that follicle that has released the egg becomes the corpus luteum, remains the corpus luteum for a couple of days unless fertilization occurs. If fertilization occurs, then it remains a viable structure that secretes progesterone, secretes hormones in order to help implantation and further develop the pregnancy. All right. Again, we will talk about that later, but I just didn't want to have a structure on here that you didn't know what it was. So that's what the corpus luteum is, okay? So, follicle stimulating hormone stimulates follicles and spermatogenesis. Luteinizing hormone stimulates ovulation and testosterone production. Again, semi-analogous physiologic processes. All right? Melanocyte stimulating hormone. Anybody remember what cells make this one? This was the weird one. Corticotropes, that's right. All right? Just so you know, because I did get questions, this is technically made in the pars intermedia. Pars intermedia is that little middle part. In lower primates, it is more developed in a separate lobe. In humans, it is essentially a part of the anterior pituitary, which is why it's not separated into its own section of pars intermedia hormone. Okay, does that make sense? It is histologically a separate piece, but it's considered a part of the anterior pituitary. Okay? In this group of peptide hormone, notice the S, right? So it does multiple different things. It's also released in skin. Everybody's heard of melanin, right? Okay. So this is what if you see this word only here, you're wondering like, what does that mean? It means that dopamine, as its hormone, prolactin inhibiting hormone, also inhibits melanocyte stimulating hormone, but only the melanocyte stimulating hormones that come from the brain, not the ones from the skin. All right? So that's what that only means. Everybody following still? All right. Thyroid stimulating hormone, what do you think that does? And what kind of cells make thyroid stimulating hormone? Thyrotropes. See, some things do make sense. Some things do. Okay? So thyrotropin releasing hormone from the hypothalamus tells the anterior pituitary to make thyroid stimulating hormone. Okay? And then thyroid stimulating hormone from the pituitary continues down the hypothalamic pituitary thyroidal axis to stimulate the processes we're going to talk about in just a few minutes when we go over the thyroid. Okay? Any questions about the anterior pituitary hormones? And all these hormones make their way, all these hormones are instructed by the hypothalamus to be created via a portal system, right? Right? Hypothalamus, anterior pituitary portal system, hypophyseal portal system. So, posterior, neuro, right? Posterior storage, and the nerves that go directly there, right? No portal system, and this is corrected. This part is connected anatomically directly to the hypothalamus, right? By what part? What's that middle? What's that part? Infundibulum. The infundibulum is the part. What's the part of the anterior pituitary that wraps around the infundibular stalk? Pars tuberalis. Okay. Very good. So smaller part, basically just a holding tank. Okay. Mostly neural tissue, doesn't make anything, stores stuff, right? And the hormones, antidiuretic hormone, and oxytocin. And again, it seems very elementary at this point. It is. We're going to talk about what those hormones do as we progress, all right? Right now, if you're here with me right now and you understand that the posterior pituitary is connected to the hypothalamus by the infundibular stalk, and that neurosecretory cells from the hypothalamus make their thing and deliver them to the posterior pituitary for storage, then you're on the right page. Does that make sense? So again, these are the hypothalamic hormones that are then released into circulation to travel to their target tissues. Okay? Got it? So there is no antidiuretic stimulating hormone. There is no oxytocin stimulating or inhibiting hormone. There's just antidiuretic hormone and oxytocin. Come from the hypothalamus, stored in the posterior pituitary, and out. All right? Fair? Okay. Just to go over the anatomy again. Directly from the hypothalamus, straight down the neurons, through the infundibulum, into the pars nervosa, right? So we attach our nerve stuff. You want to have like a simple memory trick. All of the posterior pituitary. And then it gets out through these hypophyseal veins, right? Because the collective pituitary is called the hypophysis, right? We all on the same page? Any questions? All right. Antidiuretic hormone, talk about it now. What does it do? It prohibits diuresis, antidiuretic hormone, all right? So the function is to maintain intravascular volume, maintain perfusion, and does so by literally holding on to water, telling the kidneys to hold on to water, also telling sweat glands to hold on to water. So it reduces urine production and also reduces sweating, okay? It also causes vasoconstriction, hence the name vasopressin. You'll also see it called vasopressin. alright? This one is literally titled for the things that it does, alright? But everything can't be that way. You can see if you have an ADH problem, if you can't, there's two different ways we're gonna talk about them briefly. If your kidneys can't produce it, or excuse me, if your pituitary can't produce it, or if your hypothalamus can't produce it, or if your kidneys are insensitive to it, then you have diabetes insipidus, two different versions of it, and you have an extreme diuresis, so this patient is losing a lot of water. You can see how much. Normally we pee 1 to 2 liters a day, depending on fluid intake and all other kind of factors, obviously. Without ADH, we would be peeing constantly, up to 10 liters a day. Now, are those solid numbers? But the point is well taken, I imagine, right? Okay. And in case anybody's wondering, that's why you have to pee all the time when you drink. Not just because of the increase in water that you're taking in, but because of the suppression of ADH by alcohol. So, that's why you pee all the time. So, remember, let's see where are we at? Where's my little guy? There it is. So, high blood osmotic pressure. What does that mean? Layman's terms. Yeah, those are layman's terms, and that's right. Too much shit in your blood and not enough blood. That is very concentrated blood. Yeah. And that is exactly right. Too little plasma volume, too high of a solute concentration. Typically, the osmoreceptors respond to, anybody? Sodium concentration, all right? So, basically, a very concentrated blood that osmoreceptors pick up on. We need more water in the system. We turn on ADH production, and we hold on to our water, okay? Make sense? And so, intuitively, these hopefully do make sense as well. Osmoreceptors primarily also are responsible for the sensation of thirst, because it's telling you, you need more stuff. Drink water, all right? So does that make sense why those things would cause increased plasma osmolality? Dehydration, hemorrhage, vomiting, diarrhea, right? Volume loss, fluid loss, okay? And where does ADH work? We're going to talk all about it when we get to the kidneys. Kidneys primarily responsible for holding on to water for us, right? Not uniquely, but one of the main, right? They make our urine. So what is it going to do to the urine? It's going to concentrate the urine, hold on to the water, right? So you're going to produce smaller amounts of concentrated urine, right? And then this part is the, you want to call vasopressin. Even though they're simultaneous processes, that's why it's called vasopressin, because it does increase vasoconstriction, right? So again, we're trying to maintain perfusion, because the other half of low blood perfusion or low blood volume is decreased perfusion. So we got to clamp down on the blood pressure so we circulate at a higher speed the blood that we do have, essentially, okay? Until we can expand that volume through holding on to water. Does that make sense? Okay, and again, don't forget about these little guys, right? Less significant, unless you're really sweaty, but sudoriferous glands, sweat glands. What kind of glands are sweat glands? Exocrine glands, that's correct, right? Because they secrete their stuff directly onto the surface. Exocrine glands, all right? So, has a function that affects the exocrine system as well, or the exocrine glands. Okay? And you don't have to know that list. Just know that that's why you break the seal when you can't stop eating. Right? And then stress too, right? This is sort of linked sort of into our fight or flight a little bit. We don't need to be peeing while we're running away from the tiger. So, diabetes insipidus. Everybody's heard of diabetes mellitus, right? Okay, diabetes mellitus means sweet. Mellitus means sweet. So So back in the day when they used to taste the urine, it was sweet. If it was insipid or bitter, they thought then they had diabetes insipidus, and I am not joking. So, neurogenic DI, this means that our hypothalamus isn't making it. All right, and then the sister to that is nephrogenic, right? Kidney can't do anything with it. And when you get to endocrinology, as this is not endocrinology, you will learn how to figure out between those two, okay? I'll give you a hint. ADH levels are helpful, okay? All right, any questions about ADH? Yes? No, I don't know, maybe, it increases diuresis, but I'm not sure if it has anything to do with ADH or not. I mean, the caffeine effect, the diuresis effect of caffeine is the direct diuretic effect of speeding up everything, but maybe. ChatGPT? Me versus the compendium of all human knowledge, I'm gonna lose every single time, so. All right. Any questions? Other questions? Oxytocin. All right, I added a couple words here because I want you guys to understand some more medical terminology that may not be on here, so please write them down. Stretching of the cervix is the layman's term for what we like to call is dilation and effacement. Everybody know what dilation is? Widening of the cervical os. The cervical os is the opening of the cervix into the vaginal canal. Does anybody know what effacement is? Thinning. All right? So if anybody here has had kids before, and they told you that the cervix was this much dilated and this percentage effaced, that's what they're talking about. The more dilated, the more effacement, the closer that birth is, the more impending the birth is. And that is what oxytocin does. So as the baby descends in the birth canal, the head presses against the cervix, it starts to dilate and efface. That becomes a positive feedback loop to further dilate and efface the cervix so that the baby can get out. And then when the uterus and the cervix start to involute postpartum after birth, then oxytocin is suppressed. Okay, does that make sense to everybody? Okay. And then it does something, and guys, we don't know. Hypothesized to be involved with the inability to emotionally or socially bond with others. Some of you are lacking oxytocin. All right, any questions? Because it's time for the thyroid gland. We're all on the same page up to now. I'm going to start talking about these individual glands, these individual things, and what their products do to the target tissues. Okay. So right here, right? Most of you, all of you, as a matter of fact, will sit in Clem skills and tell us that you can feel the thyroid, and you'll all be lying. In general. It's mushy. It's about right here. If you swallow right under your cricoid pouch, if you swallow, you can feel the isthmus, which is the connecting part, kind of come up and go over your finger. But in a healthy individual, basically you just feel a little bit of mush right here. You shouldn't feel a distinct thyroid. Okay? And if you do, could be normal, could be pathologic, but you'll all be like, yeah, I appreciate the thyroid, but so. Lateral lobes, wing, let me show you. It's the largest pure endocrine gland, all right? Great, who cares? But this is what it looks like. So this is, Adam's apple, your prominent thyroid cartilage. It kind of sits up here, and the two lobes. So each of those hemispheres are called lobes. Okay, and the isthmus is the thing connecting it in between. You see how vascular it is? You see some really, really, really important things going around it. So thyroid surgery is not without risk, as you can imagine. Okay. This little guy is called the pyramidal lobe. Somewhere between 20 and 50% of people have that. Okay. In here, somebody who's had some medical experience, tell me what potentially could be Christ, exactly. Now, let me answer that non-question with my own question. Does anybody give a shit about the thyroid when you're doing a crike on somebody? Nope. Cricothyroidotomy, right? If you just drop and you feel this little indentation right here where it push on it, does that? That is your cricothyroid membrane. That is where we do certain, trauma airways, right? Cricothyroidotomy, to let somebody breathe if all else has failed. So some people may have a piece of the thyroid that goes right by that cricothyroid membrane. That is immaterial. What is actually material, why it's important, is if you're having a total thyroidectomy. If you are having your thyroid removed because of chronic hyperthyroidism or whatever other reason, surgeons need to make sure that they are aware that that tissue is there, because it's not very apparent. Because when you get open, and nothing is green and red and blue like it's supposed to be, it's all just mush, right? So you gotta make sure you take out all that tissue, otherwise the patient is gonna have a subtotal thyroidectomy, which is not what they're supposed to have. So you don't wanna have any remnant thyroid tissue. Does that make sense to everybody? Okay. That's some GWAS medical knowledge for you. You can hit that. Like when you're doing your ATLS training, when you're in your airway, you're like, what about the pyramidal lobe thyroids here? And they'll be like, shut up. So, what individual working units of the thyroid gland? Cells. Now we're in the microscopic portion. Follicles are the functional unit, okay? So we're going to talk about follicular cells. If we're talking about follicular cells, essentially what we're saying, thyroid cells, functional thyroid cells, okay? Does that make sense, everybody? Synonymous. So, inside the cell is this stuff, this goop called colloid, all right? So we have these follicles, cells on the outside, follicular cells, colloid in the middle, and then we have these little guys floating around in between called parafollicular cells, okay? So thyroid cells, follicular cells, make thyroid stuff. Parafollicular cells, parafollicular, not parathyroid, parafollicular cells make calcitonin. Yes?
How do you differentiate between like these follicles and like follicle stimulating hormone with the gonads and such? So you have like, yeah, I don't know.
So follicle, okay,
I feel like
follicle,
that's gonna trip me
a
up.
follicle is a generic term for a group of cells or something that does something, right? Follicle stimulating hormone, like, I'm trying to figure out the best way to answer your question. Two grossly different functions work on two different or entirely different organs. Like the only way I think you could possibly get it mixed up, and I'm not going to do this, if I show a picture like this versus like an ovarian follicle and say what's what, like I'm not going to, that's dumb, I wouldn't do that.
Okay.
Yeah. I mean, it's not even, it's like,
Just know the context.
yeah, within the context, like thyroid follicular cell, like, we're not gonna, I think that would be the only, let me know when we get to the end of it, if there's still that confusion, and I'm not trying to be snarky.
Yeah.
I think that, I see what you're saying word association wise, but I don't think you're gonna have that problem once we get through this, okay? Just let me know, yeah. Alright, so calcitonin, we're gonna talk about what that does from the parafollicular cells. Now remember, there are parathyroid glands. Okay, those are not parafollicular cells. Two different things. Okay, that makes sense? Right now, in the thyroid gland itself, right here. Okay. What does calcitonin do? I will tell you in a minute. So, thyroid hormone secretion, right? Thyroxine releasing hormone, right? Stimulates. Thyroid stimulating hormone from where? The anterior pituitary, it says it right here. And then thyroid stimulating hormone, what does it do? Stimulates the thyroid to make thyroid hormone. Whew. That's a lot of words, okay? You got it though? Hypothalamus releases the hormone to tell you we need more thyroxine releasing hormone from the pituitary. The pituitary says we need thyroid stimulating hormone. The anterior pituitary makes it in the thyrotropes. thyroid stimulating hormone makes its way to its target tissue, which are thyroid follicles. Does everybody follow that pathway? Yes? Yes. All right. And then the negative feedback we'll discuss, right? Essentially, what happens is once we have an increased level of circulating thyroid hormone, TSH production slows down through a negative feedback loop. So the hypothalamus recognizes the increase in the production of the thyroid and slows down the stimulation of it. And that's how it sort of modulates. Okay, when that modulation is off somehow, then we go into hyper or hypothyroidism. Okay? So, the thyroid gland hormones. These are thyroid hormones, right? So the hypothalamus has made TRH, the pituitary has made TSH, and now the thyroid hormone is making T4 and T3. Okay? Everybody got it? And here's our nomenclature again. Tetraiodothyronine, triiodothyronine. Okay? So named for the amount of iodine in the compound. Okay? We're going to go through that in just 1 second. But those are the things that the thyroid makes. Okay, so when you have your thyroid checked, they will check production of TSH and they will check T4 and T3 generally. Okay? Everybody with me?
I have a question.
All right, what's up?
What does it mean by the inactive form of thyroid?
That means it's less potent, less active. So what really exerts the main effect of the thyroid is T3. Okay? I know we always check for T4, but T3 is actually significantly more active in its effect on the target tissue. Okay? Does that make sense?
So T4, once it becomes active, it will become T3?
No, there's two different circulating. T4, I shouldn't say it's inactive, it's less active, it's less potent. It does have an effect, but T3 is what has the greater effect of the thyroid. Like, hypothalamus tells the pituitary to make TSH, tells it to make this stuff. These things go to the target tissues in your body. T3 is the more significant thyroid hormone of the two. Okay? Calcitonin, all right, this is a thing that the parafollicular cells make. Easiest way to remember this, and we do have a slide for it, but I'll tell you, calcitonin tones down calcium. Okay, so it decreases serum levels of calcium. And there's a slide coming up with that on there, so if you don't want to write it down, you don't have to. Is everybody with me? Is this a lot? Can be. All right, can be. So, follicular cells, what are those? Those are those cells on the outside. What's the stuff in the middle? Colloid, right? Follicular cells make thyroglobulin. This is where it's going to become a mouthful, you guys. I just want you to know. When you straighten out all these thyroid whatever, just keep them straight. And I have checks in here to make sure we keep them all straight. Just follow along. Thyroglobulin is what is going to form essentially the backbone of thyroid hormone. Okay? Iodide, ions, right? I don't know, I made some changes, I want to make sure you understand, you see them. Iodide should be an imide. An iodide ion is a negatively charged iodine molecule. Okay? Atom, I should say. Peroxidases then change iodide into iodine. Alright? Iodine, single I. Okay? See that difference? Follow, everybody? So, follicular cells, they're making thyroglobulin. At the same time, they are oxidizing and negatively charged iodine into negatively charged iodide into iodine. Does everybody know why they put iodine in salt? So your thyroid stays healthy. So you have enough iodine to do this process we're about to go through. That's why you have iodized salt. Okay, so now, thyroglobulin's in the colloid. After it's made, it's released into the colloid. Remember, that's that stuff in the middle of the follicle. Tyrosine and iodide react together to form bonds and become mono iodotyrosine or di-iodotyrosine. So you have a thyroglobulin backbone, you have a tyrosine molecule, and you either have one or two iodines on it. That's a simple way to put it. I know this seems like biochemistry. Does that make sense? Even if it doesn't make sense, that's what happens. Okay. Now, these guys become important because these form essentially the compounds that become T3 or T4. Okay? So, I made a few changes on this slide because they are scientifically inaccurate. Now they are scientifically accurate. MIT and DIT are not molecules, they are compounds.
I have a question.
I know, hold on 1 second. And iodine molecules are not molecules, they're atoms, they're individual I's, right? They're not molecules, they are a single atom of iodine. Yes, sir, what's up?
On the last slide, you had I2 up there.
Uh-huh.
Um,
Yeah, no, I made, I didn't highlight that change. I2 right here? Yeah.
yeah, I was just wondering.
Minor change, but again, it's incongruent with the actual material, because these are I's, not I2, so I apologize. You're good catch. I didn't mean to highlight that, so I'm sorry. Does everybody know what he's talking about? It's an esoteric point, but I want you guys to understand, because if you go back and you start to do the math in your head, and you're like, this doesn't make sense, because what's on the slide doesn't jive with the words, right? The pictures don't jive with the words, so now it does. Does that make sense, everybody? Everybody seeing the changes as we go? Okay. I apologize. I'm just a guy. Just a dude with a microphone. So, molecules, these are actually compounds, and these iodides are not, okay? They're individual atoms attached, right? And so here in the red circles, we have 4 of them, hence T4, right? And here in the purple circles, we have 3, hence T3, okay? What do you need to take away from all of that? Thyroglobulin is the backbone, and the number of iodines, hence it is the nomenclature of the molecule, of the compound. Does that make sense? So 4 iodines, T4, tetra, 3 iodines, tri, T3. Yes?
So just to clarify, the T3 will always be the 2 and the 1, it won't be 3 single.
No. Yeah. So if you go, essentially, yeah, it's, no, I see what you're saying, no. It's gonna be like 2, it's gonna be a diiota and a mono. Is that what you mean?
Yes.
Instead of 3 monos? Yes, no, yeah, this is gonna be the chemical structure, yeah. Okay. All right, so now, what do we have? Almost fully cooked thyroid hormone. Almost, okay? We're in the colloid still, right? All of this is happening in the colloid. Colloid is the stuff in the middle. Follicular cells are on the outside. Now what happens? Colloid with containing this stuff starts to get pulled back into the follicular cells. Okay? Pinocytosis. Anybody know what that is? Drinking. Like Pinot Noir. Right? So the cells are drinking. It's almost like an endocytotic process, right? They're taking the stuff into themselves. Alright? And then once they're there, lysosomes chop off the thyroglobulin. And now we have T3 and T4 ready to go. Okay? Does that process make any sense? It's a lot. It is biochemistry and it is a lot. But again, the key takeaways is we have parafollicular cells, they make thyroglobulin, put it in the colloid, also suck up iodine. Iodines are attached by tyrosine and thyroglobulin in certain numbers. And then as those things pair themselves together, we either end up with T3s or T4s. And the 3 or the 4 is based on the number of iodines in it. Then those things, half-finished products, go back into the cells, thyroglobulin molecule gets whacked off, and now we have T3 and T4. We have thyroid hormone. Does that make sense? All right. Yes?
So forgive me, this is embarrassing, I don't know the name of the condition, but in like third world countries that don't have a lot of iodine in their diet, it swells up. So why would it swell up with a lack of?
We're gonna get there, as a matter of fact. We're gonna get there. So you either have hypothyroidism, sometimes you have invasion, and overuse, sometimes, or overstimulation, which is cause for goiter. You have other things that have, other substances get sucked into the cells as well. So we're gonna go over that. In underdeveloped countries, what you're referring to is actually called cretinism, congenital iodine deficiency syndrome. So there is that, it's associated with a neurologic development disorder. So we're gonna get there, okay? Okay, so are we all there with how we've got thyroid hormone ready to go? It's still in the cells right now, right? Everybody with me? I'll take that. What about over here? Yeah? All right. So we got T3, T4. So named because of how much iodine's in them. Ready to rock, right? Thyroglobulin, where is it? Gone, right? This is where it gets tricky with that. Now it goes on to thyroxine binding globulin. So TGB and TBG. I'm sorry, you guys. I didn't name this shit. All right, I'm just trying to draw attention to it. So, thyroxine binding globulin. Do you remember me talking about water solubility of thyroid hormones is very scant, small. So often, most of thyroid hormone is transported around on a carrier protein. You remember that? Thyroid hormone is on the list of water soluble hormones, but it's got those asterisks on it. This is why. Water solubility is low, so most of it goes around in or on a transport protein. Most of it on thyroxine binding globulin. Another 20% to albumin in the systemic circulation, okay? Then there is this little part called transthyretin. And what do you think, if this makes it into the cerebrospinal fluid, what do you think the unique function of transthyretin is? Crossing the blood-brain barrier. Remember the blood-brain barrier, right? Okay. This has the ability to cross into the blood-brain barrier. This has to do with what we were talking about, the neurological development. What is thyroid doing in the brain? It is creating axons, it is creating new specialized kind of cells. It is there for neurological development and during development. And then in adulthood, it is still crucial for cognition, awareness, motor skills, mood, okay? So there is, T3 being able to get into the brain is crucial for the development of the neurological system and the maintenance of it, all right? So we have this takeaway. Thyroxine binding globulin, and what is a globulin? It's a protein, it's a big protein. When you see that word, that's what that means. And albumin take around 90% of the systemic circulation, the remaining 10 go with transthyretin into the CNS. Okay? I wish it was more exciting again. As good as it gets. Critical concept. They're not the same thing. Okay? Thyroglobulin is that initial backbone that helps us form the hormone. Then it gets taken off. And then as it goes out of the cell, thyroxine binding globulin is what carries it around the body to go to target tissues. Okay? People mess that up. That's why this is on here in 2 different colors. Alright? Alright, That's, I think I'm a minute past my break time, or your break time, I take that back, so you guys take a break and we'll come back to finish.
It says there's two mechanisms, and one is like, it says target recognition and then like the other two look very similar.
So the target, specifically the target recognition, that one isn't a toxicity but rather a prevention. So that's what's gonna prevent them from just killing everything. So
And when it looks, the two, are these the two different ones, cause they look the same?
no, so one the two mechanisms it's gonna destroy is the first one, which is in here, which is the granule release. So that's releasing both peptides and
To do the,
And then the second
one,
yes, and the second one is that
and that's what this is, where the receptor
Yeah,
just matches.
it's gonna touch it and then it's
But
gonna
it's saying the opposite, it's just saying that the NK cells have a ligand to it, but then over here it's showing that.
So like these are two ways to kill, just go on the way to prevent. So it's basically saying if it sees the individual, so it's like okay, well,
Yeah, it finds it, it recognizes it.
yeah.
It's starting to come along, trying to get the little marker. It says CD40, I know it shouldn't have it on there. That's how it recognizes the B cell.
So yeah, so CD40 on B cells will co-stimulate with CD40L on the T cells. So those two connect.
And I feel like that's important also now.
So really on them, the important ones to know is some CD3, which is
Mature.
it shows mature T cells, and it's what allows it's the T cells that allow them to do the BT cells, and then you have your pushes T48, L3, and cytotoxins, and they're gonna bind to those MHCs.
And what is it? Is it CD7?
So that's CD7, CD28, which then binds to B7, and then you have your threes, and then CD19 is mature B cells.
this is the pattern that I'm gonna do.
Yeah.
Like I just gotta,
I'm like,
I'll think about you on the weekdays.
I'm thinking like, so, like I said, everything I looked at yesterday was so much. And then we had, we were obviously like, I was getting to this
This is my new mark now.
You want to be doing like 4 or 5 hours.
It was a good build up, you know. It started That's my favorite song.
Oh,
I bet. It is a good song. My favorite. Downward fiction rolling.
You take a picture after.
I was just
Oh, really?
You're not accepting it too closely. I had that whole big song with Lil Price.
He has a couple of songs that are okay, but then I just like he wasn't talking about it.
Biggie has better party.
Yeah.
And stay Tupac.
But
Yeah, listen to that one.
I've never heard of it.
Whenever someone pisses me off, I would say it's I know all my another sad one is I like try to chopped and fruit like action is good. I like chopped and fruit. I think I bought like
It's like the statute of limitations. We were all like, we don't know, right? 5 years.
like rap camera.
Should be fast.
I like listening to old raps, and not like new rap. So
Needless to say, we never had a really 3D. But
Do you like Martin? I used to love some of that.
think about my girlfriend. Can't think about it. You don't know.
I would read on top.
All right, everybody, we're almost done. We actually are really close to being done, you guys. So, any questions that you came up with in your intense discussions about thyroid hormone creation over the break? No? Alright. So, this is a hidden slide, because I just found it, but I'm gonna send it out to you guys later. It rolls it all up, okay? It's essentially 7-step, more or less, but it just takes you down, so all of that information kind of puts it into one little chart. If things like this are useful to you, I'm gonna send it out to you later. So it synthesizes everything into one little piece, okay? Any questions about thyroid creation, thyroid hormone creation? From the hypothalamus to the pituitary, to the thyroid itself, anybody? Okay. All right, so what do they do? Generic overview, what do thyroid hormones do? Essentially, they make you more active, they increase metabolic rate, okay? So, increase metabolism. How do they do that? One of the ways, they stimulate sodium potassium pumps, which increase ATP production and turnover. You guys know ATP at this point, I assume? Adenosine triphosphate, okay. So, energy. So it increases energy production and turnover, so it increases metabolism, right? It regulates metabolism by stimulating synthesis and increasing energy utilization. It enhances the actions of catecholamines. What are catecholamines? Epinephrine and norepinephrine, right? Okay. So, generically, when you're hyperthyroid, generically, you have a lot of energy, you're hyper, your heart palpitations, you have a high body temperature, you're always hot, okay? Generically, when you're hypothyroid, slow down, more sensitive to cold, gain weight, metabolism slows down. So that's a very generic way to think about hyper versus hypothyroidism. And if you can remember that, then you can sort of tease apart the actions of T3 and T4. Does that make sense? Too much thyroid hormone, hyperthyroidism. Speed up, everything's too fast. Too little, hypothyroidism, everything is too slow. Does that make sense? If he's seeing the actions of the hormone itself? Okay. Synergistic with HGH should make sense, we're talking about energy production and utilization of protein, fats, and so on and so forth. Okay. And we're going to talk about this deficiency, and mostly what it has to do with is neurological development. And we're going to get there. We're going to talk clinical correlations now. So hypothyroidism. Anybody know anybody who's hypothyroid? Anybody experience hypothyroidism? So generally, again, some of the signs and symptoms of people are insensitive or very sensitive to cold. Heat intolerance, right? Cold intolerance are two different things, right? Cold intolerance on the hypothyroidism side. A lot of times they lose, their hair thins and they lose it. They gain weight. They complain that they can't lose weight specifically. Sometimes you see it manifest as a goiter. Okay? So, mixed edema is one form of hypothyroidism. In this, you're asking, why are there goiter? These mucopolysaccharides can accumulate not just in the thyroid, but in other tissues around the eyes. And one form of mixed edema that you might have heard of, if anybody has any medical background, is pretibial mixed edema. So you have this fluid and tissue accumulation on your shins, essentially, the front of your tibia, okay? So, puffy features, hoarseness, stiffness, right? Everything slows down. Pre and post treatment, you can see these features. It's not weight loss, it's just a correction of the hypothyroid state that then results in the regression of that fluid and mucopolysaccharide accumulation. I know this isn't in your slides, this is just GWiz at this point. Not only does this guy need a pedicure severely, but that's pretibial myxedema. Alright, so an accumulation, sort of a rough, and it sometimes gets, confused with stasis, venous stasis, because it looks similar. But that darkening of the skin is hemosiderin, which is a compound in your blood. And that myxedema is that thickening and hardening of the skin, sort of the alligator-looking skin. So that's pretibial myxedema, alright? Hypothyroidism in a childhood, formerly known as cretinism. Yes? Myxedema coma actually is a very, very severe form of hypothyroidism. It is a life-threatening, oftentimes it's fatal, even with treatment. So that, remember when I said that levothyroxine can be administered IV? That would be a severe myxedema coma. So basically it leads to such a slowing down of all the processes that you essentially go into a shock-like state almost, right? And so myxedema coma is the far extreme of hypothyroidism. Like normal hypothyroidism's kind of more in the middle. It's actually the most common one we're going to talk about next. But hypothyroidism in childhood, cretinism, and again, we talked about T3 and its function in neurodevelopmental processes. The development of neurons, axons, the differentiation of different types of neuronal cells within the central nervous system, right? If that is not there because there's insufficiency, generally an insufficiency in iodine intake, this is usually why this is a problem, then you have stunted growth, you have a slower neurological development, and so on and so forth. Right? This is probably the most common cause of hypothyroidism that you would see in clinic. So clinically, this is if you have somebody who's complaining of cold intolerance and gaining weight and all that stuff, this is what I would think of. Hashimoto's thyroiditis, Hashimoto's disease, synonymous, okay? So these people generally will have the goiter that you see, right? And what you have here is an autoantibody. So thyroiditis, Hashimoto's disease, and it's an autoimmune attack on the receptors on the thyroid for TSH. So the pituitary is making a ton of TSH, but it's not relating to the thyroid producing any thyroid hormone because the receptors are insensitive to the TSH. So the message is being sent, it just can't be received. So you have this overwhelming amount of TSH, very, very high TSH, very, very low T3 and T4, incongruent levels, right? Couple that with the clinical syndrome of weight gain, slow metabolism, cold intolerance, and then you have thyroid disease, okay? And what do you do with this? Yes, no? Treat it. You give them some, you can give them Synthroid. That would be the oral bioavailable format. You give them Synthroid, synthetic thyroid hormone. Okay? Then what happens? Negative feedback starts to kick in, evens out, right? Hypothalamus starts to recognize the rise in thyroid hormone because of the synthetic thyroid hormone that you were giving the patient. Turns off the thyroxine releasing hormone, turns off the TSH or turns it down at least, and now everything kind of stabilizes. Okay? Hyperthyroidism, okay? So these people are fast. Heart palpitation, always giddy, eyes are bugging out of their head, okay? Losing weight, can't stand the heat, right? Generically, if you remember that's how you recognize hyper and hypothyroidism. Yeah.
Sorry, just a quick question about the hypo. If you're doing a crank and you accidentally cut the thyroid, would you end up with hypo? Would it stop?
No, not really. I mean, honestly, unless you might cut the isthmus a little bit, but you would have to grossly mess up, if that makes sense, the cut in order to really screw something like that up that bad. So I can't imagine, I can't conceptualize a crank injury that would necessarily lead into hypothyroid. It's also a fairly remarkably resilient gland. So even if you do cut a part of it, the rest of it's still going to work sufficiently to, Graves' disease, hyperthyroidism. Anybody remember First Lady Barbara Bush? Her eyeballs look like they were bugging out of her head. Anybody? Is that a bridge too far. Laura Bush's mom. Right. Wasn't Laura Bush's mom, that would be weird. You guys want. Hyperthyroidism, Graves' disease. It is essentially what happens is now we have this autoimmune disorder. We have a fake thyroid stimulating hormone, more or less. Okay, think about it that way. So, in this case, we have a very, very low level of thyroid stimulating hormone in our blood when we measure it. We have a very, very high level of T3 and T4. Okay? So the hypothalamus isn't telling the pituitary to make TSH. The false TSH, the autoantibody, is acting like TSH and having the thyroid turned on constantly, even though the levels of T3 and T4 are sufficiently high that the negative feedback loop should work. Does that make sense? So the production line is just on at the thyroid, so this patient chronically has these super high levels of T3 and T4, right? In that case, they get palpitations, they lose weight, their eyes bug out of their head, they get all kinds of, they get the goiter. Thyroid eye disease, if anybody's paying attention, there's a lot of commercials for medicines that treat thyroid eye disease. You get an infiltration of the musculature around the eyes, so you get that exophthalmos, which is the protrusion of the eyes, okay? It is reversible to a certain extent, all right, but not necessarily completely, depending on the extent of the exophthalmos, again, which is the protrusion of the eye. It might not fully regress even with treatment, but treatments have improved significantly that make the cosmetic outcome much, much better than it used to be. It used to be untreatable almost if you had severe Graves' disease. So I put this in here, not that you need to know, but it's not necessarily just the removal of thyroid tissue, it's the ablation of the thyroid tissue. So a thyroidectomy, taking out the thyroid, is one way. You can also ablate the tissue with radiotherapy, other different things. So there are multiple different ways to treat hyperthyroidism by sort of literally killing the thyroid itself or taking it out. Then that person would be on supplementation with synthetic thyroid hormone as well. Okay? Because again, they can't make it just to maintain a euthyroid state. So euthyroid is where we're at. Right? Our thyroid is doing what it's supposed to. So Graves' disease, right? Before and after treatment, like she's not doing that on purpose. That is just, you get thyroid eye disease, and then you can get a, the patient can have a chronic conjunctive or chronic scleritis, exposure keratitis because their eyes are just chronically open wide, so exposed to more air than they should be. Lacrimal ducts are not sufficient to keep them moistened all the time, so this patient can have chronic red, dry, itchy, painful eyes in addition to the exophthalmos. So again, the treatment improvement is not just cosmetic, it's also very functional to maintain this patient's lifestyle. Hyperthyroidism, like I said, fast, right? How many of you here knew that Synthroid is a drug of abuse for people who want to lose weight? It is, right? If you go to some of these fly-by-night clinics or fly-by-night personal trainers, you can get they will offer you Synthroid. Don't take it. Because you know what happens if you take Synthroid long enough? You shut down your endogenous production and then you have to stay on Synthroid so you can be alive. Alright? You will also, by the way, future clinicians of the world, have patients ask for it. Well, not anymore, because now people want Ozempic, but back in the day, yeah, can I get some Synthroid because I need to lose a few pounds for the tape test? Like, no. You cannot. But they'll be surprised. All right, any questions about the thyroid? We're going to talk quickly about the parafollicular cells, and then we're going to talk about the parathyroid. Real fast, and we're going to be done.
With the Hashimoto's, you get them on the Synthroid and you're able to reverse everything, everything's working normal. Hypothalamus is secreting and they're making T3, T4. Over time, can you wean them off?
You can dial it down, but most of the time you won't be able to take them off because the autoimmune will kick. It's an autoimmune disease, so eventually if you take them off, it will kick back in general. But you can dial it down. Now, we give Synthroid, in micrograms, so if we can keep them on the lowest dose possible, but most of the time those folks are going to be on it. Yeah. Okay, so parafollicular, no, straighten out. Parafollicular cells are different from the parathyroid glands. Everybody got it? Okay, where are the parafollicular cells? On the outside of the follicles in the thyroid gland. We're still in the thyroid gland. Okay? In the thyroid gland. Okay? Calcitonin, briefly. It actually is pretty intricately linked with what parathyroid hormone does, just to make things confusing. But calcitonin tones down calcium, okay? That's the easiest way to remember it. It has an antagonistic effect on parathyroid hormone. Okay? So in recognition of low serum or high serum calcium, this will take the following action. Hold on. Go here. I'm going to come back, don't worry about it. This is what calcitonin does. It doesn't, the slides say it inhibits osteoclasts or increases osteoblasts. It doesn't increase the number of osteoblasts or osteoclasts. It changes their activity, okay? It changes what they do or how much they do. So an osteoclast chews bone. Clasts chew, blasts build. Okay? So by inhibiting osteoclasts, which chew bone in order to reabsorb their calcium, they keep the calcium in the bones and they tone down the overall level of serum calcium. They also decrease how much calcium we can absorb in our intestines, and they increase a process known as calciuresis, or easily known as calcium in your urine. So, they will reduce how much calcium we keep in the gut, increase how much calcium we lose in the pee, decrease our bone reabsorption by osteoclasts. And the combined action, or sum total, will be a decrease in serum calcium, toned down calcium. Does that make sense? Everybody? Okay, let me go back. So, just so you know some terminology, resorption is using something, reabsorption and absorption is partially is like reutilization. Alright, if those terms, we'll talk about them a lot more when we get to kidney, but for right now, chew and build. So osteoblast build our bone. So increased osteoblastic activity takes calcium from the blood, puts it in the bone. Okay? Increased osteoclastic activity takes calcium from the bone and puts it in the blood. Does that make sense? Okay. Okay, that's parafollicular glands. They make calcitonin, which tones down calcium by increasing how much we lose in our urine, decreasing how much we keep in our gut, and decreasing how much we reabsorb from our bones. Does that make sense? Okay. Parathyroid, essentially the opposite. Parathyroid glands, what are they? They're 4 little dots on the backside of your thyroid gland. Okay? They make parathyroid hormone. Finally, something that is named for where it comes from. Okay? Just so you know, you might also see it called parathormone. It's the same thing. Okay? So it is the opposite of calcitonin essentially. It brings up calcium in the serum. Alright? Where's the parathyroids? These little guys right here. On the backside, this is a posterior view. On the backside of the thyroid gland. Para, as in adjacent to the thyroid. Just from some gee whiz for everybody, when they do a total thyroidectomy and take those out, they will take your parathyroid glands and stick them in your forearm in general so that you still have parathyroid activity. Okay? Why in your forearm? I don't know.
What are they attached to? I don't know.
Muscle, stuff, sinew, bone.
Put that here.
All right, so this is essentially the opposite, literal opposite, inverse of the calcitonin slide. Okay, so it increases osteoclastic activity, right? Wait, yes. Because it's trying to increase calcium, right? It's an increase in calcium. So it increases the chewing of the bone to put the calcium into the blood, right? It decreases osteoblastic activity because they build bone with that calcium. All right? It decreases calciuresis. We want to keep the calcium. We don't want to pee it out. And it increases how much we absorb through our nutrition and our GI tract. So all of those sum total is to increase serum calcium. Does that make sense? It does. That's it for today. Right? I don't think I heard that. So, does anybody have any questions? All right, well, enjoy lunch and the remainder of your day. Good luck tomorrow morning. I'll see you tomorrow after the test.